Just want to say hello to those who are coming in. We're going to get started in just a moment or two. We're going to give it a chance for everyone to join, but we are glad that you're here. All lines have been muted just to prevent background noise, but we certainly encourage you to utilize the chat box or the Q&A feature if you have any questions or concerns now or throughout the presentation. And we are right at the top of the hour, but I'm going to give it just another minute. I know that there's a lot of competing priorities for folks that want to give folks a chance to log on. All right, great. Well, we will get started just for the sake of time. I'm sure we'll have more join us in just a few moments. Hello and welcome to this webinar on promoting vaccine confidence in older adults. My name is Ariel Mather, and I'm the program manager of the National Center for Equitable Care for Elders. We are joined today by two fantastic guest speakers from the Lowell Community Health Center in Lowell, Massachusetts, and I'll introduce them in just a few moments. If you have not attended one of our activities before, just a little bit about our center here on this slide. We have been around a few years as a part of the Harvard School of Dental Medicine as a national training and technical assistance provider for HRSA for health centers who are serving the vulnerable population of older adults. We have a variety of learning opportunities that are going on now, and certainly that will be upcoming. So we encourage you to check out our social media platforms and our website for more information on that. We include this slide in every activity we've done over the past year. Certainly, it's been a long past year. There's been a lot of resources put out around COVID-19 now that are very much focused on the vaccine program. Always like to plug the Health Center Resource Clearinghouse. It's a great one-stop shop for especially the National Training and Technical Assistance Partners materials. So if you have not already checked that out, I encourage you to do so. I also want to put in a plug for those who might not be aware that there is a bi-weekly special populations roundtable happening for the Health Center COVID-19 vaccine program. Our next session is actually tomorrow, but we'll have another session on April 23rd and May 7th, all focused on creating a space for health centers to join and share their experiences being part of the vaccine program, which now has been expanded to all health centers. So we encourage you to join us tomorrow afternoon, and for any of the other sessions, they're all from 1 to 2 p.m. Eastern. And we're very familiar with the Zoom reminders at this point, but just to make sure we're on the same page, all lines have been muted to prevent echo and background noise, but we have the Q&A feature as well as the chat box for you to interact with us during the session today. You will see a little message in the chat box from Juliet on our team, just reminding us that the chat box defaults to just sending messages to panelists. And while we love to see it, we want everyone to be able to see your feedback and your questions. So feel free to select panelists and attendees when you chat. This session is being recorded. We are going to send out an email after the session wraps up with a PDF copy of the slides. We will also link to our YouTube channel where this recording will be probably in the next couple of weeks once we get it closed captioned. So we look forward to providing those resources to you. And when you close out of this Zoom session today, a webinar evaluation link will pop up. We'd love for you to take just a couple of moments to give us your feedback. We will also make that link available via email as well. Great, so let's jump into our learning objectives for today. We are hoping that you are going to leave this webinar being able to a little better explain factors that influence vaccine confidence, particularly for older patients, perhaps to identify some strategies to make informed decisions with patients around the COVID-19 vaccination, and hopefully be able to think of some additional ideas to collaborate with your community leaders to improve vaccine acceptance. We also hope for those of you who especially are part of a health center vaccine program, if you want to share your successes and challenges, we would love that as well. So feel free to utilize the chat box throughout this presentation. Great, so let's begin with just a quick review of where we are this week-ish in the vaccine rollout. We do know that unfortunately over 555,000 Americans have died so far from COVID-19. The majority of those deaths have been among persons over the age of 65. But we are starting to get some better news. According to the CDC, over 167 million vaccines have been administered. You can see on this slide that a little over half of older adults have been fully vaccinated, with many more having received at least one dose. And we're quickly approaching the end of the various vaccine phases, with President Biden's recent announcement that every adult in the country will be eligible to be vaccinated by April 19th instead of the original deadline of May 1st. Most states have grouped older adults in a pretty high up phase of vaccine distributions, usually about the second phase. But there's not been consistent agreement on where the age brackets were initially targeted. So for instance, Maryland has focused on adults 60 and older, while neighboring West Virginia first targeted folks over 80, then moved to 50 plus until they made doses available to their entire adult population in later March. So we'll talk briefly about some of the logistical barriers of receiving a vaccine in just a minute, but want to certainly acknowledge that while vaccine availability is indeed improving, a higher number of available doses or loosened eligibility requirements does not necessarily mean that everyone will quickly and easily be able to secure an appointment yet. And since health centers are our primary audience for our training and technical assistance work, I wanted to give another shout out to the Health Center COVID-19 vaccine program, which, like I mentioned, as of yesterday, has expanded its eligibility to all FQHCs across the country, which translates to about 520 more health centers. And of course, many of those have several sites being added to the previous list. So NPR put together some graphics to explain the progress of the vaccine rollout so far using CDC data. You can see this information is just from a couple of days ago, but the link will have even more updated info. We can see the percentage ranges for states, progress between the teens and 20s when it comes to fully vaccinated populations, meaning they received either both doses of a 2-shot regimen or a single dose vaccine. Researchers have estimated that around 70 to 85% of the country needs to be immune for COVID-19 to stop spreading. And it's also estimated that we might reach that point by early September. So we will see. It's another map that you can see even higher percentages here for those that have at least been partially vaccinated. You can see there's variations across the state, really strong New England representation here. After a slow kickoff in December, vaccine administration has clearly steadily improved in scale and efficiency, and we do expect these numbers to continue to rise dramatically. But that doesn't mean that we don't have work to do. So many of us have heard this process described as trying to build the plane while we're flying it. So the variations in phase timing, vaccine supply, and sign-up procedures across states has contributed to many of these issues listed on this slide that relate to problems older adults have encountered in trying to get vaccinated. We also know that the socially isolated and seniors of color may disproportionately experience inequities related to resources like technology and transportation, which can further limit chances to secure or attend a vaccine appointment. Many community-dwelling older adults are homebound to some degree or experience health conditions that could impact their ability to get out of the house. These members of the community are often overlooked, particularly in locations where there are not active mobile healthcare programs. These barriers should not be confused with reasons for vaccine hesitancy, but it's important to keep them in mind in order to understand the various reasons for slow vaccine uptake and to work to address them alongside efforts to boost vaccine confidence. So vaccine hesitancy has been a very hot topic over the past months, but it's important to be sure we have a similar reference point for what that actually looks like in the community. So these are individuals that are either delaying or refusing a vaccine on more of a case-by-case basis. So these are not the folks who choose to get any and all recommended vaccines, nor the ones who refuse them entirely. This is more of a selective mindset and could depend on the time, the place, the vaccine itself. Older adults who are vaccine hesitant would fall in the middle of this acceptance continuum. So either identifying as getting most of the recommended vaccines or at least getting a few. Research does indicate that the likelihood of getting all recommended vaccines increases with an individual's level of income and education, and there are some noticeable differences between racial and ethnic groups. Attitudes towards other vaccines may help us better understand indicators of acceptance for the COVID-19 vaccine. And the AARP 2020 flu vaccine survey showed a number of motivating factors behind the vaccination of older adults. You can see some of them here and also pretty quickly see some parallels with what we've been hearing around fears related to the COVID-19 vaccines. Those can include side effects, how effective it is either in the short or long term, or perhaps an overall belief that the vaccine isn't necessary because someone feels as though they are in good enough health. Through the National Poll on Healthy Aging, based at the University of Michigan's Institute for Healthcare Policy and Innovation, we did see a decrease in COVID-19 vaccine hesitancy in early 2021 compared to numbers in fall 2020. This 71% on the slide represents those over the age of 50 that indicated they were now ready to get vaccinated when a dose became available to them, or that they had already been vaccinated by the time they were polled. Other older adult focused surveys have shown that while there's a high percentage of individuals open to getting vaccinated, many within that group expressed wanting to wait a few months before receiving it. We do know that misinformation can certainly impact behavior, and assumptions or rumors that the COVID-19 vaccine might require some sort of a payment or pose a significant threat to their health or the well-being of their family members could act as a barrier to seeking out or following through with vaccination. But there are other general concerns related to the speed of vaccine development or unanswered questions that many of us have had around asymptomatic infection or transmission that could also be a deterrent. This is where we're going to potentially see a stronger desire to wait and see before accepting the vaccine. It's also crucial to acknowledge the gaps in attitudes about COVID-19 vaccination between racial and ethnic groups that are in part influenced by negative healthcare experiences, historical trauma, especially for African Americans. We also know that the clustering of social networks that share similar vaccine-related attitudes can also influence the persistence of vaccine hesitancy among groups of people. Institutional and interpersonal distrust requires that those involved in education and outreach, that they tailor their approach so they can adequately address these very real questions and concerns. So when we're saying we want to address vaccine hesitancy, we're really wanting to promote a sense of vaccine confidence. There are so many factors that influence the vaccine decision-making process, whether that be social, cultural, political, but ultimately there needs to be trust in a variety of things, including the vaccine, those administering the vaccine, and the whole system of development and production. So you may already be taking advantage of some of the resources on the CDC page that's linked on this slide. There are guides, conversation starters, slide decks, assessments, communication toolkits that can help those patients who want more information about the COVID-19 vaccine, including the development process and safety data. So here's just a little bit more context about the CDC Vaccinate with Confidence strategy, which is divided into 3 parts. You can see build trust, This is focused on sharing clear and accurate messages, leading with transparency on vaccine development and the ongoing efforts to monitor safety. This also involves being clear about what we don't yet know. And proactively addressing misinformation with the help of community partners and trusted messengers. Empowering healthcare personnel, this involves all staff working in healthcare settings, from physicians to pharmacists to community health workers, focuses on promoting their confidence in the decision to be vaccinated themselves and recommend the same for their patients. The goal is to ensure that the whole healthcare system is equipped to create and maintain a culture that builds vaccine confidence through empathetic conversation and tailored messaging. And finally, engaging people and communities in a sustainable, equitable, inclusive way that can look like encouraging vaccine recipients to share their stories with their communities, working with partners to ensure vaccination sites meet the needs of the local individuals, and really identify and collaborate with those trusted messengers to make sure that the vaccine messages being shared are reaching everyone. So this slide echoes many elements of that vaccinate with confidence strategy, but I wanted just to highlight a little bit more specifically the importance of addressing community distrust, particularly as we've seen this pandemic magnify inequities across the public health sector. This resource linked on the slide on community engagement from the American Psychological Association acknowledges that marginalized populations have experienced higher rates of COVID-19 infection and resulting deaths, and that many special and vulnerable groups, including some older adults, will face additional challenges during periods of recovery than those with more resources. Recommendations include not to avoid acknowledging community distrust towards public health officials, but rather to discuss it, create a space where people can speak freely, will actually give some great insight into specific reasons for vaccine hesitancy, and hopefully assist in creating those tailored messages to address those concerns. Depending on your state or county, there could be many groups working simultaneously to ensure safe and equitable vaccine distribution, and collaborating with as many public health officials or academic or healthcare associations as possible can ensure that those resources are used effectively and there's less duplication of effort. Partnerships in this area can help to build community confidence in your vaccine program. And there seems to be more research every day on the COVID-19 vaccines, but it's important to consider who's reviewing that information, and presenting that information as well. If there's a way for local leaders and trusted messengers in the community to review this data and feel comfortable with the information, they can potentially engage with those who remain hesitant or who are very focused on outdated or less reliable research. These leaders know their community well and can help to communicate vaccine information even more effectively, perhaps, than some of the national level resources. The link on this slide is for the playbook for vaccine confidence in age-friendly cities. It's developed earlier this year by the Global Coalition on Aging. They had a partnership with Age Friendly New York City and the New York City Department for the Aging. Their goal was to engage older adults to build trust and confidence in the COVID-19 vaccine, as well as underscore the importance of older adult vaccination in general. In doing so, the organizations hope to not only help control the COVID-19 pandemic, but also serve as the leading edge for healthier future of life course vaccination and active aging. So this playbook is very long. I hope that you take a look at it. It's a great resource, but they did outline several key communication principles when addressing some of these challenges that might negatively impact vaccine confidence. You can see them on the slide, but I'll mention them briefly. So of course, we want vaccine-related messages to have accurate and clear information, but delivered in a way that acknowledges hesitancy without judgment. Older adults can really benefit from hearing stories from their peers' perspective on getting vaccinated and how perhaps they feel more protected or excited to get back to activities they miss. Vaccines are a medical treatment and, of course, do come with risks and side effects, but so much is being done to make vaccines safe and encouraging older adult patients to not only think about the vaccine itself, but the disease it can protect them from can really help to put things in perspective. And of course, so many of us can relate to wanting to reunite with loved ones and find a sense of normalcy again. And framing vaccine messages with this hope for the near future goes beyond just the experience of older adults, but really applies to everyone and their safety. And finally, we want older adults to feel confident in pursuing many key health steps to support healthier aging, which during this time includes the COVID-19 vaccine, but also involves other risk reduction activities, including chronic condition screening and management, long-term care planning, ensuring this population is up to date on all their vaccinations and healthcare services truly supports healthy aging overall. So that was a little bit just a foundational information. I'm excited now to introduce our guest speakers today. We're very excited to have them here from the Lowell Community Health Center here in Massachusetts. I will go ahead and read their bios to you now. Dr. Robert P. Marlin is the Chief of Meta Health Center and the Chief of Department of Family Medicine at the Lowell Community Health Center in Lowell, Massachusetts, where he also serves as the Associate Chief Medical Officer. He previously served as the founding director of the Coordinated Care Program for Political Violence Survivors at the Cambridge Health Alliance. Dr. Marlin received his medical degree from the State University of New York at Stony Brook School of Medicine and his PhD in anthropology from Rutgers, the State University of New Jersey. Dr. Marlin received his MPH in health policy from the Harvard School of Public Health and completed the Commonwealth Fund Fellowship in Minority Health Policy at Harvard Medical School, where he concentrated on the intersection of US health and immigration policy. His work focuses on care integration and the development of community-based interventions to advance the health and well-being of refugee and immigrant populations. So joining Dr. Marlin is Sheila Ocha, who currently serves as the Chief Public Policy and Equity Officer at the Lowell Community Health Center. In this role, she leads community health strategies, leads the development, design, implementation, and evaluation of public health programs with a focus on racial and health equity, and oversees advocacy efforts on federal, state, and local public policies to advance the well-being of her community. Recognized for her cultural competence and language access expertise, she has worked with organizations throughout the state and region to effectively deliver services that meet the social, cultural, and linguistic needs of all patients. Sheila received the 2010 Greater Lowell Health Alliance Community Catalyst Award for her accomplishments in the development of cultural competency and medical interpreter programs. In 2015, she was the YWCA of Greater Lawrence Tribute to Women honoree in recognition for her work championing equity and social justice. In 2018, Sheila received the Nonprofit Alliance Kathy Redeker Executive Leadership Award and the Massachusetts League of Community Health Centers Advocacy Award. Sheila holds multiple degrees and certifications, including a BA in Community Health from UMass Lowell, master's degree in Public Health from Boston University, and an advanced certificate in Financial Operations from Suffolk University. Sheila also holds a Massachusetts state certification as a community health worker. So I'm so excited to turn this presentation over to Dr. Marlin and Sheila now. Thank you both.
Good afternoon, everyone. Can you all hear me? Okay, thumbs up. Excellent. Buenas tardes. It's so great to be here. Thank you so much for inviting us. I'm going to be looking at different parts of my screen because I do want to see at least the panelists. I know I can't see the participants right now, but thank you all so much for joining. Thank you so much for that introduction. It's always difficult to almost hear the bio being played back to you. I do want to say that before all that, I am a community health worker, an outreach worker by experience. Those were my beginnings in public health, and I'm also a medical interpreter. So a lot of what I will be speaking to throughout this presentation focuses on the community education aspect of the work that we have been doing at Lowell Community Health Center. And then Rob is going to help us and walk through his own experience as we are promoting vaccine confidence amongst our patients and what we are seeing. There are no disclosures for either of us for this presentation, so I'll dive right in. So for Lowell Community Health Center, as you're able to see here, we were established in 1970. We're a federally qualified community health center, as many on this call right now. And our history has been such that we are working towards the equitable delivery of services for our entire greater Lowell community. As you are able to see on our mission, one of the key components of it is that we do provide culturally competent health services, and that has been in the making for a couple of decades at this point in terms of what was just talked about, the tailoring of our services, the tailoring of our approach, not only culturally, but linguistically for our very diverse population. So to kick us off, I'd like to introduce to you Fernando. When we launched a vaccination 6 weeks ago for patients 75 and older at our health center, we were anxiously waiting on how this was all going to pan out, supporting our staff who had spent hours upon hours preparing for this moment, all knowing that this was history in the making. Many questions were swirling in our minds. Will our patients come? How will we do? Did we reach enough people with education? Did our intense community outreach efforts work? And then Fernando walked in smiling, our very first COVID-19 vaccine patient, on time for his appointment. Fernando is a 75-year-old Spanish-speaking man walking in with a joyful spirit, just as he had walked into our health center many times before this pandemic. Hola, he said, smiling, and this kind of smile that we only see now through someone's eyes because we're all messed up as we're walking in different public places. And he sat down and he was ready for business. With our nurse, a trained medical interpreter, assuring he understood everything that was being discussed, he received his very first dose of the COVID-19 vaccine. Now, his appreciation for us calling him, us reaching out and providing him the vaccine in his home, his medical home, can't be overstated. Patient after patient after that, all with the same energy, hope, and optimism, really renewed our energy and further affirmed our role as a community health center in our community. So with that, Dr. Marlon's going to walk us through our city of Lowell and who we are.
So thank you, Sheila. A little background and context on where we operate and who we serve. So the city of Lowell has long been an immigrant city, but this has become even truer in the past few decades. And Lowell's now home to families from Africa, Asia, Central and South America, especially those areas where human rights are in jeopardy and where the conditions of war, torture, and trauma abound. Lowell's home to the second largest Cambodian community in the United States, approximately 30,000 people, and to a growing number of immigrants and refugees from other countries as well, including Cameroon, Liberia, Sierra Leone, the Democratic Republic of the Congo, Kenya, Iraq, and Burma. And especially important for us is that over 42% of our community speaks a language other than English at home. And these are very important considerations for us to take into account when designing and implementing services. Next slide.
So here you see a graphic containing a lot of the information of who we are as a health center. So that was the city of Lowell itself and the incredibly vibrant diversity that exists, incredibly beautiful for us. I love working in the city of Lowell for that reason. So for us at the health center, on average, we provide close to 32,000, we see close to 32,000 unique patients per year. We have about 145,000 visits. Patient ethnicity breakdown, about 32% of our patient population is Hispanic, Latinx, 26% white, 22% Asian, predominantly from the Southeast Asian community. And within that, within the Cambodian community, 12% Black, representing many different African countries and ethnicities. And about 8% a mix of different races, whether it's 2 races or more, and the like. Of note on this slide is that 41% of our patients are best served in a language other than English. And within that patient population, that meant for us, at least during calendar year 2020, that we provided medical interpretation at 58% of our medical visits. That was double the rate from pre-COVID conditions, especially in a virtual environment.
So we wanted to try to understand, as we got ready to start vaccinating, how many of our patients and community members would potentially be willing to be vaccinated. So we used Mass Inc. survey data to try to get at this. And like many other institutions, we initially conceived of a continuum among our patients ranging from hesitancy to acceptance. However, the term hesitancy really places the onus on the patient, as if to say, why did they hesitate to accept our advice? And for us, this is akin to the clinical labeling of patients who choose not to follow recommendations of their clinicians as, quote, non-compliant. So both put the burden and the implied fault squarely on the patient, implying poor judgment on their part and sometimes dismissing their agency. So as we began to develop our plans for vaccinating our older patients against SARS-CoV-2, we quickly shifted our frame to one focused on access, and specifically equitable access. So this means examining access to vaccines, information about them, and related resources through the lens of equity. And once equitable access is accomplished, the fundamental element in actually having patients decide to be vaccinated is trust, as Ariel mentioned. Communities must trust their healthcare institutions, and this is usually the case for on-the-ground actors like FQHCs and lookalikes, who are known quantities in the communities they serve and are part of these communities. And as this recent survey data from Massachusetts reveals on the right, however, Black and Latino residents have the greatest trust specifically in their primary care clinicians, not institutions. And for most patients, trust is built over time with their primary care clinicians. And these long-term individual relationships are the cornerstone of care for older patients. But trust must also be something that can and must be established in the moment. When meeting a new older patient for the first time, a physician, NP, nurse, pharmacist, or community health worker must also either build trust or support the trust that's already been established with the team or the community health center. So when considering whether or not to be vaccinated or choosing a vaccine, clinical team members must demonstrate that vaccination is right for that specific individual patient. Even if you told them before, tell them again in the moment as you're asking them to schedule a vaccination, or when you're in the process of vaccinating them, or you've already vaccinated them. Every interaction is an opportunity to build trust or lose trust in the SARS-CoV-2 vaccines and in healthcare generally. Just as with the influenza vaccinations, in my own clinical experience, about 75 to 80% of my patients who initially say no to SARS-CoV-2 vaccination say yes after a one-on-one discussion with a clinician or another trusted member of the clinical team. For many of our older patients in Lowell, clinicians must also earn the trust of family members, in addition to earning that of the patients themselves. Patients will often defer to their family members, including their children, on such healthcare decisions. In these cases, we need to treat the family and the community as our patient, and not just the individual older patient. This means demonstrating respect for the communal aspect of healthcare decision-making while still respecting the agency of the individual patient. We must always keep this in mind, even given these dynamics. And we can't assume who an older patient is, who would typically defer to family members. I've seen that many of my patients in their 50s, a demographic group I would typically consider middle-aged, occupy the position of elder in their families and communities, and naturally defer to their children for decisions about vaccinations. Trust is also continuously earned when we show respect for patients' questions and concerns about the vaccines, and there are no foolish questions. We must be able to answer any question or concern, even if some of them seem outlandish to us. Many of us have heard questions about microchips being injected along with the vaccines, or the idea that the vaccine itself would give a patient COVID-19. It's far too easy to dismiss these notions as absurd without attempting to answer the underlying concerns that they demonstrate. We must keep in mind that many elders in our communities will recall US government programs that purposely left STIs untreated in African American men so as to watch the natural evolution of the disease over decades, and sterilized Puerto Rican and Native American women without their consent. These are just some examples. Such ideas demonstrate a distrust of the healthcare system that's well-founded and rational, and we have to respect that. Patients may have justifiable questions about the vaccines themselves, as Ariel mentioned, including the speed of its development as a risk factor and what its ingredients are. We've heard from Muslim and Buddhist religious communities in Lowell who have raised questions about the inclusion of fetal material in SARS-CoV-2 vaccines, despite the fact that this is not true and there's no such element present in the vaccines. And we again address these concerns and advise that this is not the case, but inaccurate information and rumor abounds in what is often a vacuum, especially for isolated elders. Next slide.
So with that context, it was incredibly important for us to really think about how we were going to tailor our patient and our community education approach as it related to the vaccine. And as we learned the vaccine was coming, this was November, December timeframe, we launched a campaign associated with this, looking at our aims, identifying our population of focus, and then components of an educational campaign, if you would. Now, our aims were really to assure, and still are, to assure equitable access to accurate information, vaccine information, for the reasons that you just heard. It's incredibly important for us to do that. And then another component of it was, to increase the vaccine confidence. So instead of saying decreasing vaccine hesitancy, once again, echoing what Rob just talked about. Now, for our populations of focus, I'll bring your attention to the message ambassadors. And this is also mentioned on the CDC vaccine confidence toolkit that they have. It is important that we are inclusive. We knew that we were going to need help, not only from ourselves or our providers or our community health workers and our staff all across our organization, but also our community partners, community influencers out in the community to be able to help us deliver this message to assure the broadest reach possible for our patients and for our community with correct information.
And a key element, as we've mentioned, is language access for our patients. For the large number of our older patients who don't read or speak English, their access to information is far more limited. We therefore focus on having interpretation available to them, including for vaccination visits in line with class standards, as we mentioned. And we also have written and verbal information on vaccination available to them in their primary languages, again, keeping with our focus on equitable access. So we've been prioritizing outreach to older, limited English proficient patients of color who across our state and the country are not being adequately vaccinated at the same rates as white English-speaking patients. And every encounter is an opportunity for education around vaccinations. We want to take every single opportunity to provide education and vaccination for our older patients. So calling them directly is a key component of this effort. It makes it much easier than forcing them to call us and trying to schedule or ask questions. And when patients are being seen for other clinical visits, not vaccine related, that's also an opportunity to ask them if they're interested in getting vaccinated. And if not, it's also an opportunity to educate them about vaccination and the risks associated with COVID-19. In many cases, we're able to offer our older patients vaccinations right after their primary care visits, saving them an additional trip and the logistics involved. Another key area of concern for us is technology access. For our patients who are not on site, communication and outreach can be more challenging. Many of our older patients, especially those who are poor, do not own computers or have computer-based internet access at home. And this is often the easiest way not only to schedule vaccinations, but to receive information about vaccinations and health generally. Many of them have low health literacy, and even when they can access internet-based resources, they don't know which ones to trust. They then become reliant on those around them, friends, family, service providers, and for limited English proficient elders, all of these issues are compounded by the difficulty in accessing reliable information in their primary language. Many of our elders are currently isolated, even from friends and family, and may have no information resources to rely on apart from their primary care team or their home care team, who they may not see regularly right now. Next slide.
So it's clear that this is beyond outreach. It's truly about community engagement on multiple fronts. So an enormous amount of capacity building and awareness also amongst our staff. Not on the slide, but equally as important is supporting our staff. Vaccine hesitancy is also a real issue amongst healthcare staff. So we have efforts as well on that front. So for example, early on in December, one of the very first things we did was to publish initial talking points for our staff, answers for patient questions, to equip them with what we needed. We then very quickly, and this was right before the holidays, our infection prevention nurses did and conducted train-the-trainers for our community health workers in our organization. And we did that purposely because we knew people were going to be gathering over the holidays, whether virtually or in person, and they needed to be equipped with the talking points to be able to navigate that, because there was a lot of conversation on this. So beginning to plant the seeds and beginning to increase capacity. Now, as part of our efforts on the community education front, we partnered and are currently partnering with the Greater Lowell Health Alliance, which is a coalition of about 80 plus organizations in our Greater Lowell community, nonprofits, faith-based, city government, and the like. They have really graciously made themselves available to help bolster our efforts, which is great. So we are unlikely to see every one of our older patients for a visit during the window period for vaccination. We are reaching out to organizations and institutions that interact with them on a daily basis, whether that is the mutual assistance associations, elder day programs, religious organizations, or other community-based organizations, as I have mentioned, right? These are our trusted messengers, these are our partners, and they're helping us carry that message. So in essence, it's really extending the clinical care team and the circle of trust with our patients and community. Here you're able to see the what and the how on the slide, education as well as outreach methods and example. On the education front, it's incredibly important that we know our information, that we stay current, and that we stay present. We present the information in an accurate manner, because honesty does equal trust. Even when we do not know the answer, being able to say, I don't know it, let me find it for you. In many communities, as we've heard, there's a ton of misinformation about the virus, there's widespread concerns about things like data privacy, and there's just a general distrust of healthcare institutions amongst communities of color. There are also community concerns regarding negative consequences of providing personal information to outsiders. So people not wanting to take the vaccine because of those reasons. So for example, myself as a community health worker, I am a trusted messenger. I meet people where they are, and many CHWs do the same. And it's essential for us in our building of trust in the community, which is a key component of what we're talking about here today. Now, given our unique role as outreach educators, as community health workers, as health center staff, it's very important that we're in spaces within our community, and it's equally important for those questions to also come back to our organization. And for us to address the specific concerns, Rob talked about there are no foolish questions. They're not. It's very important. So for example, we created a comparison chart of all the vaccines, or the top vaccines that are being utilized worldwide, specifically of countries where our patients identify from. And the reason why is we need to remember that social media has no geographic boundaries. And our patients are receiving information and might be getting confused with vaccines being utilized in Cambodia, in the Dominican Republic, and in other places. And we needed to provide information across all fronts so that they were able and are able to differentiate between what's approved here in the US versus in other countries. Likewise for our community health workers so that they're able to deliver that message. So that's the type of tailoring and the type of questions we were getting, whether it was in WhatsApp or Instagram, that we felt, this is going to be important for us. So all of this needs to really be done with empathy and with encouragement always. And it has to, of course, be done as we're talking about outreach strategies, going to barbershops and corner stores. I will need to say that we also need to do it with appropriate COVID-19 precautions, which adds some level of limitation to the amount of outreach that we're able to do. So on the next slide, you're able to see the questions that we ask our community influencers and leaders. And this is when we got together with 30+ organizations. We've been meeting on a weekly basis with them. We asked these questions that you see on the slide. And the answers to this question is what helped inform our educational campaign. Now, on the next slide, we're able to see examples of what we jointly created with our community partners and with those who were part of this process. We created multilingual materials that really were in tune to our community. They included pictures of what we say are images, our stories, and our people, and all of it using information from the CDC as well as the Massachusetts Department of Public Health. We just adapted it and made it our own. We also made sure that the materials were in the languages that our community speaks. So for many of us who are bilingual, we really put our translation skills to work. Health literacy was another component. So we wanted to make sure that as we were explaining things like mRNA, that we were doing it in a way that people understood it. That was very important. And then we adjusted our entire website, a lot of social media posts for those who are able to access social media. And then we created a lot of public service announcements that are being aired on local television, which is highly viewed by a lot of specifically Cambodian older adults, and in other places across our community, where we have community health workers and when we have providers and influencers speaking as to this is my why, this is why I got vaccinated, this is where I was, this was my process. But we also have community health workers asking providers questions. And here, when they're asking those questions, it places two trusted members of the community together, a provider as well as a CHW, while a provider is giving accurate information on the vaccines itself. So on the next slide, you can see examples of some of our community-based educational activities. One was a podcast, that's the picture on the top. The bottom is a virtual town hall. That's our Chief Clinical Services and Incident Commander, Elizabeth Hale, who was presenting to a large group of people on vaccine effectiveness. One of the key components on the slide that I will touch on is the obtaining feedback from community partners. Every single time we have presented and we are posed a question that perhaps wasn't posed before, we bring that right back to the team and say, how do then we weave in the answer to that question into our approach and to our educational components as we go through? Because we have to really listen to our components. And again, echoing, there are no foolish questions. We need to answer them all. So as we are doing our education, of course, now we turn into, okay, great, I'm ready. And it's really important for us to be able to help our community and our patients navigate the system while being culturally responsive as we do that. So these are very critical components. I will touch on the first two boxes, and Rob will take us on the motivational interviewing side of the house. But here we're able to help determine if someone is eligible, assisting people with registration. If you have been through any of the registrations, I'd say vary greatly depending on where one is going for registration, linking people to transportation resources, of course, supporting language, acting as a bridge. I think it's important to note that at times our communities and community members and patients are very able to navigate through. Their only level of support that they might need is truly the interpretation of the language. So again, from a point of empowerment, always asking the level of support that someone might need. It is about being able to provide education that is accurate, that is fact-based, And important to use respectful, bias-free, non-stigmatizing language. One of the components that we always, when I do trainings with community health workers and medical interpreters, we say, oh, we need to remain impartial. What's interesting here is that we are encouraging people to get the vaccine. So the impartiality piece gets tested a little bit. So when someone declines a vaccine, we need to continue to push the conversation along gently while respecting in a non-judgmental way, understanding, again, from an empathetic standpoint, from an encouragement standpoint, always. Now, if we have insufficient consideration to the history that has been outlined or culture, we may unintentionally result in loss of credibility, confusion, and further misinformation. So we really need to watch out for that. Rob?
So motivational interviewing, for those who don't use it, is a key technique in healthcare, but it's been especially important for us around vaccination. Vaccinations are for SARS-CoV-2. We use techniques such as motivational interviewing to build trust, as we said, which is so key, and empower our patients. So the elements in this model are a great fit, especially for our older patients. Expressing empathy through reflective listening, demonstrating the gap between a patient's own goals and their actions, avoiding direct confrontation, acknowledging patient resistance, and supporting individual agency. So these are all very important, but beyond the benefits of the specific techniques, our older patients recognize that we respect them and value them when we take the time to have a conversation like this with them about vaccines and their importance. Just another note on transportation, which Sheila brought up a bit. For some older patients, just getting to the health center is a major challenge, and many of our older patients don't drive and may not have a friend or family member, especially now, who can transport them. So even those with coverage through Medicaid or Medicare for transportation may have difficulty organizing this and coordinating it with their vaccination appointment. For those who cannot, we need to consider bringing the vaccinations to them via mobile vaccination units, which are starting to happen in places in the state and throughout the country. For some patients, including housebound elders, all of these access issues come together to keep them from getting vaccinated right now. And for this segment of the population, we ourselves are now considering how to develop mobile services that can provide vaccines. And I just want to make a special note for our older Asian American patients. Some of them and their family members are fearful of leaving the house or coming out in public right now, given the recent attacks on Asian Americans, including elders. For them too, having mobile vaccination teams that come to their homes or their neighborhoods would allay some of these fears and be another tool in achieving equitable access. Next slide. So our focus on equitable access has already proven successful, and the early results of our vaccination program show the benefits of this approach. During our first week of vaccinations, we vaccinated 249 older patients. Of those, 114 were Cambodian patients. And this is 46% of those vaccinated during that period, a far greater percentage than this population represents in Massachusetts or the US generally. And this is a testament to our community-centered efforts and the trust built and enjoyed in our community. We have earned our community's respect and most importantly, their trust by focusing on those with the greatest needs. Next slide. So we're committed to equitable access, as you've heard, and demonstrate our accountability to ourselves and our community by publishing our vaccination rates by race, ethnicity, and age on a regular basis, as you can see on the slide. We want every one of our older patients to feel as positive about getting vaccinated at our health center as Fernando did. And we know that our work will not be done until that's the case. Next slide. Thank you.
Wonderful. Thank you both so much. We have several minutes for questions. I want to give folks a chance to type things into either the Q&A feature or the chat box, but I have a few questions too, so I might start with one and then we'll see what others might have. But I guess first, since Dr. Marlin, you were recently talking about using motivational interviewing strategies, And I can think of a few goals that some of your older patients might have when you're thinking of developing discrepancy between what they're doing now and their goals. But could you talk a little bit about some of the goals you heard in those conversations, or that some of your clinical staff heard?
Sure. Above all, they want to be safe and healthy. They want to be able to interact with their families without putting their family members at risk or themselves at risk. And they want to get back to being outdoors and being able to interact in the community. Those are really the primary goals. But they also say they don't want to be injured in any way by getting vaccinated. They don't want to have any additional risk for either disease or problems that come up with vaccinations in their mind.
Sure, sure. Yeah. I'm wondering too, I know Sheila mentioned briefly that it wasn't on the slide necessarily, but that a component of your work was to focus on or on boosting vaccine confidence for your staff as well, because we know that that's going to translate to the conversations one-on-one that staff are having with patients. But curious if you could talk a little bit more about that, and if anyone on your staff was able to, in conversations either with peers or those they supervise, use maybe some of those same MI techniques to help resolve some of their ambivalence.
So our staff represent the community, first of all. So they have the same concerns as the community does. They're more knowledgeable, but they share similar concerns. So we make sure to carry out educational activities with our staff on a regular basis and update them. So that's really the primary mechanism. And in some cases where people are hesitant, we have tried to use motivational interviewing, but we're respectful, knowing that our staff have good clinical knowledge. If they decide they don't want to be vaccinated, we have to respect that. But it's very few people.
Sure, sure.
Feel like you have more?
Yeah, and then one of the things, the same notion of community influencers and testimonials that we talk about for community also work with our staff. So we had some very early adopters that said, absolutely, I'm getting the vaccine, and they had no issue saying, take a picture, like, let's do this. And slowly it helps build confidence for others as well. That worked really well for us, but definitely a lot of conversations, similar to what we're having now in a space like this, with a lot of our staff, a lot of one-on-ones, answering questions, and not putting over pressure on someone to make a decision, but truly just providing information and meeting people where they are in their learning, in that motivational interview has a contemplative state, right? And helping people move towards the action side on that continuum, or rather that cycle, as they're ready.
Sure. Yeah, wonderful. Yeah, I'm curious as well. In the foundational slides that we have, I mean, certainly some research is saying, okay, well, maybe there's opinions or attitudes around other vaccinations could give us a clue around how folks might feel about the COVID-19 vaccination. But I'm curious from both of your perspectives, if that felt true for your populations, if there was a difference, given that you have a really diverse community in Lowell. I'm curious if you can speak a little bit more to that, if you found some similarities to other, conversations in the past around someone who might not be really confident about other vaccines, or does this feel especially unique?
I think it is similar in many regards, but it's just exponentially stronger. So I'm thinking of patients who are concerned about getting influenza vaccines every year. Those are often the patients who are also concerned about this, but it's a larger group because of the rapidity of the development of the vaccines, and they're so novel for many people that a greater number even have concerns. But yes, the same people who you see saying, I have concerns about flu vaccines every year, are also the ones concerned about this.
Sure. Okay, well, wonderful. Well, I am going to assume that a very quiet chat box and Q&A just means that all questions that folks might have had were answered, or that folks are really reflecting on some of the information that was shared. So I want to wrap us up here with just a thank you first and foremost to Dr. Marlin and to Sheila for all of their time and expertise in sharing the work of the Lowell Community Health Center. And if anyone on the line is finding that they have questions after the fact, or they want to learn a little bit more around community partnerships or educational strategies, feel free to reply to the email that you'll get with the PDF of the slides and other information. We can always pass questions along. Again, if you are from a health center and want to join that vaccine roundtable, would love to see you tomorrow, Friday, April 9th at 1 p.m. Eastern. And again, we would love to hear your feedback. Very quick survey is going to pop up after you close out of the Zoom. We'll also send it in your email. Would love to just hear your feedback, as well as if you have any comments or questions for the Lowell team. Want to thank everyone for their time and attention today, and take care. Have a wonderful afternoon.